Hi, everyone. My name is Julian Hedstenberg. I'm Director of Research and Evaluation at MANNA and the MANNA Institute, and welcome to our seminar today, Hospital Malnutrition Today and Bridging the Gaps to the Community Tomorrow. Yeah. Click where? Today, our agenda is, I'll give you a short introduction to the MANNA Institute. I'll talk for a minute about Malnutrition Awareness Week. We'll have our presentation, and that will be followed by a question and answer session. Please put your questions in the chat box. You can put them to everyone, or you can put them to me directly. Tell you a little bit about the MANNA Institute. The MANNA Institute is a division of MANNA, where we are conducting evaluation and research projects that explore the impact of nutrition on health and health for people with serious illnesses. We have research and evaluation initiatives. We also educate healthcare professionals and consumers, and we share best practices and findings so that we can improve service delivery and transform healthcare to the role of food as medicine. We are partnering with ASPEN, the American Society of Parenteral and Enteral Nutrition, and their Malnutrition Awareness Week. We're an official ambassador this week. There's a series of seminars that you can sign up for. They do have CPEUs for them. And if you use the special code MAW/MANNA, you can register for the seminars for no cost. The link to register them is at the bottom, and we encourage you to do that. You will also get one CPEU for today's seminar, and we will send you that CPEU certificate after this session. So today I'd like to introduce our speakers, Lauren Hudson and Kristen DeWills. Lauren is currently Assistant Executive Hospital Director of Clinical Operations and Director of Clinical Nutrition Support Services at the Hospital of the University of Pennsylvania. Lauren's a registered dietitian with over 30 years of experience at Penn Medicine, developing and managing a progressive clinical nutrition program and interprofessional team. She's an experienced clinical nutrition leader who has been successful in growing a respected nutrition program, which has received a Team of Distinction recognition by the American Society for Parenteral and Enteral Nutrition. She has experience in applying informatics, enteral and parenteral safety and system design, and has published work in this area. Professionally, she is a member of the ASPEN Malnutrition Committee and has conducted research in quality improvement interventions in the area of malnutrition outcomes, and works on related malnutrition initiatives within the organization. Kristen DeWills is the clinical manager of the Clinical Nutrition Support Services at the Hospital of the University of Pennsylvania and an adjunct professor at Immaculata University, where she teaches medical nutrition therapy in the graduate nutrition program. Kristen is a Medicare provider supporting adults living in the community under the Adult Autism Waiver, which bridges her interest and commitment to clinical nutrition in the community setting. So welcome, Lauren and Kristen, and I'm going to transfer control to you to start your presentation. So can I mute?
Yeah, where's that? Hi, everybody. Thank you, Julianne, for the introduction. Today, Lauren and I are going to be talking to you about hospital malnutrition today and how we are bridging that into our community through our connections with at Penn Medicine into our community around us. So our objectives today, what we're going to go over is, first, we're going to talk about the history of malnutrition. Then we're going to define malnutrition today. After we do that, we're going to talk about how we implemented the A&D Aspen criteria in an acute care hospital, how we leverage the electronic medical record to support malnutrition documentation and coding, how we use this information to gather a lot of malnutrition data, and then moving forward, how we are currently using this data to help bridge the gap between the hospital malnutrition and the community. So first, just taking a look back at the historical definition of malnutrition. As I'm sure you're aware, it has varied over and has changed over the course of the years, over the course of decades. If we look back into the 1920s in the United States, when pediatric malnutrition was the main public health problem, it really started here, and the providers were looking at a subjective physical assessment, but then kind of progressed to looking at weights, looking at heights, and looking at trends. Then in the 1940s to the 1970s, there were still some studies that came out, but at this time they referred to malnutrition as simple starvation. There was two specific studies at this time. One was with a group of consenting adults, and another was a group of those in a Warsaw camp during World War II. So during these studies, they actually looked at malnutrition as in terms of just not getting adequate intake, which showed weight loss, changes in behavior, edema, also decreased blood pressure, temperature, and weakness. In the 1970s, some of you might have even read the article, The Skeleton in the Hospital Closet, which was one of the first articles that kind of highlighted what could happen to a patient while getting treatment in a hospital. It talked about, as those were critically ill in the hospital, what can happen just due to the disease process and everything that's going on, how patients can lose weight, how their lab values can change, and also contribute to malnutrition. Here is a time when they were looking at more objective data. Again, it wasn't as subjective. It was looking at anthropometrics, so weight, arm muscle circumference, tricep skin folds, and also they took a look at those biochemical markers, that albumin, lymphocytes, micronutrients. Again, that objective information is kind of what they were looking at so that they can kind of use this criteria across populations. In 1980, some of you might not really realize this because sometimes this is a fight that we're still kind of fighting, is that biomarkers were challenged. So they were kind of looking at the albumin lab values and kind of challenging that with new research. This is when the subjective global assessment came about. This is when providers were actually looking at specific disease states and researchers to see how, as the disease progression went, how the body's affected. How, for example, in older adults, sarcopenia, looking at body composition versus nutrient intake. Again, this is the time where we were looking at those with AIDS and cancer and seeing how their bodies and their composition was being affected by the disease state and their critical illness. In 1988, this is actually the first study that came out and showed that malnutrition increased hospital costs. So even in the 80s, they were saying how those patients which were critically ill and had malnutrition did cost the hospital more money. But again, still at this time, the definition was very ambiguous. There wasn't a set criteria that people looked for. In the 1990s to the early 2000s, again, more research came out, still looking at disease-related and lean tissue evidence that was becoming more established. This is when we were kind of focusing on identifying patients who might be at risk. A lot of our nutrition screening tools came out during this time. So our MUST, our nutrition risk screen, or MNA, or MST, all of these screening tools came out during this time. You know, different ones just looking at how can we identify patients at risk that would benefit from a nutrition intervention. This is also when the idea of stress-induced versus starvation-induced came to. So it wasn't just the one-sided of starvation, not getting enough nutrition, but also bridging that disease states and the stress too that can have the effect. So looking at from 2008 to now, a lot has changed. There was a study in 2008 that proposed a new definition, which would bring in actual disease pathology and inflammation. Along those lines, technology improved. We're using BIA, looking at fat-free mass, and realizing too that everybody's kind of different and looking at body composition and how that affects people within their disease states. In 2012 is when the AND-ASPEN consensus criteria was published. And then also GLIM is our global criteria that we'll review during our presentation as well in 2018. And during this time, obviously, I'm sure you're aware, we're focusing on documentation, interventions, and kind of using all of the information that we've gathered over these decades to help build our nutrition practice. So today, we should all know that malnutrition is should not be just looking at visceral proteins, looking at albumin, because albumin should not be a sole indicator of malnutrition. Again, the albumin, those negative proteins will be decreased when someone does have inflammation or is in a critical disease state. Also, there's a decreased synthesis of albumin and other visceral proteins that will alter oncotic pressure and promote fluid accumulation. So again, like I said in the couple slides beforehand, in the 80s, this is when this kind of idea was kind of challenged. But again, too, it should be just talked about as well, because as it can come up during everyday just discussions within patient care. Aspen is actually on the verge of publishing a visceral protein position paper, which should be out this month. This was developed by several members of the Aspen Malnutrition Committee, and it was presented to the board of directors in August and approved. So just to kind of keep an eye out for this paper, it does talk about Aspen's position on using visceral proteins when assessing patients, and kind of the data behind it, and how we shouldn't be using it as a sole indicator for malnutrition. So all of those decades of research has really come to Aspen and the Academy of Nutrition and Dietetics coming up with a consensus criteria, which was established in 2012. So again, they took all of the research, again, not just a starvation-related malnutrition, but again, they bridged in that inflammation, the chronic disease part. So I'm sure these next couple slides might be a review for you, but this is the criteria that is currently accepted to define malnutrition and what we use at the hospital of the University of Pennsylvania. So here we can just take a look at the etiology as either starvation related, or it's related to a sort of inflammation, either a chronic disease, such as organ failure, heart failure, cancer, a chronic illness, or something that's acute, whether it's an infection, a burn, a trauma. All of these things have been identified to be causes or etiologies for malnutrition. Within these etiologies, we always look at the following criteria, which are required to make that diagnosis for malnutrition. So below are the criteria that the dietitian will look at and to identify. The patient needs to have 2 of these criteria in order to make that malnutrition diagnosis. So we look at specific weight loss, insufficient energy intake, loss of subcutaneous fat and muscle loss, fluid accumulation, edema, and diminished functional status as assessed by hand grip strength. So this criteria, again, was published in 2012. The University of Pennsylvania actually adapted and started using this criteria in 2013. So here is a more specific outlining the criteria. As you can see, some of this might be a review for you, but just to kind of bring back to the history, as the researchers were always looking for some discrete objective data. So this is kind of what these guidelines have bridged. There's certain criteria, and then there's certain guidelines in which we assess the patient and we make selections based on what's going on with them clinically. So again, certain amount of intake over time that the dietitian will assess, a certain amount of weight loss over a certain time period, and then looking at the severity of any fat loss, muscle loss, edema, and then just decreased grip strength. So like I said, we adopted this in 2013, and I think the most important thing that I can tell you today, one of the most important things, is that what we're going to be sharing with you throughout our presentation has been in the works for about 8 years. So again, we took these guidelines in 2013, and we kind of made our program how it is today, which took a lot of education. As you can see our timeline here, the first couple years we kind of focused on educating our staff, new and the existing staff, making sure everybody was competent. We have annual competencies to make sure that everybody understands the malnutrition guidelines and documentations. We have documentation standards that we have developed over the past years to make sure that when we are documenting malnutrition, it's very clear. And we have changed it over time too, just so that when the providers look at our notes, they can easily get our information for coding as well. We've done clinical audits for compliance. We did a lot of education. Again, over the years, we've learned a lot. And as we did get our data, there was things that we could tweak in our program and our education and our documentation, which we have worked on through the years. We have gotten specific tools such as the hand dynamometers. And all of this has helped us most recently to get really good reporting and really good data on our patient population. So again, we have done a lot over the past 8 years. It wasn't just we adopted the guidelines and that was it. We've worked really hard over the past just to get to where we are today. So one of the most important things that we did once we adopted the guidelines was to leverage the electronic medical record to make sure that what we were assessing was documented in our notes. So we built discrete data fields to reflect the consensus guidelines. We have our EMR, which I'll show you a picture of, is basically a decision tree, which helps the dietitian guide their diagnosis. So again, these criteria can be kind of cumbersome, especially if you're new to practice. So this will actually help guide the dietitian in their decision. And then more of which Lauren will talk about too, that when we do document, we have certain alerts that providers do get so that we can leverage the medical record even further. So as you can see here, this is just a screenshot of our malnutrition assessment that's in our electronic medical record. We use Epic. So these were discrete fields that we had built. We had an old computer EMR before we moved to Epic, which we learned from and then kind of put into great use when we switched to Epic. We got very discrete data. So as you can see here, when someone's assessed for malnutrition, there's either a yes or a no. And then as you click through the etiology, the decision tree will open up. So if it's an acute illness identified, all of the acute criteria will pop up, and then the dietitian will move forward and select the criteria that the patient meets. So again, they can go back and look. You know, even for this example, there's the severe, it tells you what's severe, what's moderate, and then at the bottom, they can make their final malnutrition diagnosis, whether it's moderate, whether it's severe based on the etiology, or if they have not met the diagnosis at all. We also know that a large part of our malnutrition diagnosis is our nutrition-focused physical exam. So this has been implemented into our EMR as well. So we have a specific section here that when the dietitian completes her NFP, his or her MFP, that we can put the data in. So you can see the physical findings, if it's gotten from a provider, if the nurse has helped with the assessment. And then again, we can click through specific muscle wasting, fat wasting, fluid accumulation, and what specific body part is affected, and if it's mild or if it's moderate or severe. We also have discrete data fields here for hand grip. So for those patients that we do test hand grip on, we're able to put that documentation into our note as well. So this is just a snapshot of our progress note, which shows what the data would actually look like within the dietitian's documentation. So here you can see very clear malnutrition diagnosis. The patient meets established criteria for severe protein calorie malnutrition. It's very clear that the specific criteria that they met. And then also at the bottom is the NFPE. So if there's any question about the fat loss, the muscle loss, the fluid accumulation, the provider or even the dietitian that last saw the patient can go and easily see what was last assessed. So now I'm going to pass it over to Lauren. She's going to tell you the rest of our malnutrition story and tell you about documenting and a lot of our patient quality and initiatives that we've had.
Okay. Hello, everybody. Okay, so I'm going to continue with our story of malnutrition here at the Hospital of the University of Pennsylvania, but we'll pause for just a brief moment to really ask the question, why is documenting malnutrition important? And I think the most significant reason why we want to document malnutrition is because it impacts the quality of patient care and patient outcomes. We know that early recognition and treatment of malnutrition does drive quality of care and outcomes. If we can provide appropriate nutrition interventions, we may be able to reduce complications and even length of stay. And if we can provide nutrition intervention throughout the phases of care, we may also be able to prevent readmission. I think that documentation of malnutrition is extremely important to supplement the face-to-face and verbal communication that the nutrition team is having with our providers, and it can really just overall improve communications within the electronic medical record. And finally, documenting malnutrition can help our health information management colleagues in terms of the volume of retrospective queries that they need to do with our providers to risk adjust our patients. We all also know that documenting malnutrition is important and absolutely needed for coding for malnutrition. So this is something that I'm sure many of you are familiar with, but our malnutrition diagnoses can be and are reportable secondary diagnoses, particularly in the case of severe protein calorie malnutrition, which is a major comorbid condition. If a patient's primary DRG can accept a major comorbid condition, and particularly if that patient does not have another MCC, then coding for malnutrition, severe malnutrition, can impact reimbursement at a higher rate. And I think most importantly, coding for malnutrition impacts hospital performance. It allows us to risk adjust our patients, and therefore it will impact such hospital-wide measures as severity of illness, risk of mortality, and most importantly, the hospital's performance on mortality index, which is the observed or actual mortality versus the expected. With coding for malnutrition, however, we do know that it's not enough for the registered dietitian to document malnutrition. We need to see, and the coders need to see, providers documenting and supporting malnutrition. So as we kind of continue our story, we had really solid documentation on the part of the clinical nutrition support team, but we really needed to take a look at provider documentation. And this was particularly important because around the time that we started to focus on provider documentation, external to our organization, the Center for Medicaid and Medicare Services were conducting audits. And these audits were focused on malnutrition, and they were overturning claims. And the underlying issue for rejecting payments was related to lack of support within provider documentation. So at the time, we pulled together a interdisciplinary group of folks, myself as the director of nutrition support, the director of our health information management department, several representatives from the billing compliance office, as well as clinical documentation improvement. And we actually got together, we reviewed audits that were happening in some of our sister hospitals. And we really stepped back to look at what the current state was. And we made a decision to do two things at that time. One was that we needed to develop our own UPHS or health system provider guideline for the diagnosis and documentation of malnutrition. And we felt we needed to do that because CMS was really inconsistent in the standards that they were applying to diagnose malnutrition. So we felt it was important to have our internal guidelines so that we could demonstrate that our providers were following our guidelines. We also determined that we had opportunity to create some audits and also support provider documentation. So as we started to move forward in developing our guideline, at the same time, the Global Leadership Initiative on Malnutrition was published. And so this is a consensus report. It's very, very similar to the A&D Aspen consensus report, in that the real aim of this was to standardize the diagnosis of malnutrition. And this group was actually really interested as well in making sure that they provided guidelines that were applicable across different types of clinicians, particularly clinicians that did not have nutrition expertise, and across different settings. So this was truly a global initiative. There were nutrition experts from around the world. They worked together for 3 years, and they did come to consensus on a two-step model. And this included criteria for diagnosing malnutrition, as well as addressing nutrition screening. And so this is a schematic of the GLIM criteria. It starts at the top with a recommendation to use a validated screening tool. The assessment includes both phenotypic as well as etiologic criteria. There is then the requirement for one of each of those criterion to actually diagnose malnutrition, and then a severity grading. And I'm not going to go through the details, but I think what you can see from this is that the phenotypic criteria very much aligns with A&D Aspen in terms of a measurement of reduced muscle mass, weight loss. What this criteria includes that Aspen does not is BMI. And I think that's particularly important because that's an easy measure, particularly for non-dietitian type of clinicians. And then you'll see that the etiologies really do align with A&D Aspen in terms of addressing inflammation and reduced food intake. And then this is just the criteria that determines severity of malnutrition, and consistent with A&D Aspen, there is a moderate and a severe level. And so with the fact that we had the clinical nutrition team well established using A&D Aspen, and GLIM had some elements to it that were really appropriate for providers, we were able to integrate both of the guidelines to create that UPHS provider guideline for diagnosing and documenting malnutrition. So we had met our goal, we had a framework for our providers, and we also had a platform then to move on to establish a documentation tool that would support our providers. This is just a snapshot of that guideline, and you can kind of see the intersect between A&D Aspen and the GLIM criteria. And so then what this is showing you here, a busy slide, but I'll walk us through it. We then move forward to create an alert. And in EPIC language, that's called a best practice advisory, and that's shown up here on your right. And how this works is that if the clinical nutrition support service has diagnosed and documented malnutrition, when the provider accesses the patient's chart, the provider will be presented with this alert. It indicates to the provider that the patient meets criteria for malnutrition, and it also suggests that the provider consider the use of a UPHS malnutrition smart phrase. And so if the provider opts to use that smart phrase while they're documenting in their progress note, they are then going to be presented with the actual clinical nutrition findings. And you can see that up here in the blue highlight. So the dietitian's findings and assessment will appear for the provider. And then the provider is directed to this bottom section here as they move through the smart phrase, where the provider is asked to make an independent diagnosis of malnutrition. And it also gives the provider an option to indicate that the malnutrition does not have clinical significance for that episode of care. If the provider does select a malnutrition diagnosis, they are then required to use the pick list that you see here. And so the first pick list is malnutrition findings. That is then kind of drives the provider to actually supporting his diagnosis, and then requires the provider to also indicate an intervention in a plan. So with this, we were really able to close the gaps in terms of provider documentation. And this just gives you a little snapshot of what that provider note section would look like. So through all of this, we really did have a significant impact on coding for malnutrition. So if you start on the left-hand side of our timeline, if you will, when we first had robust coding reporting from EPIC, about 40% of our patients who were identified by the clinical nutrition support team with malnutrition went on to get coded at discharge. So only 40%. You can see that we implemented the best practice advisory towards the end of fiscal year 17, our smart phrase here, and then we rolled out the provider guideline here. And as you can see, with each initiative, we were able to really impact coding 83% in fiscal year 19 to where we currently stand today, which is that 87% of the patients that the dietitians diagnose with malnutrition will go on to get coded at discharge. Now I'm going to just move forward a little bit and talk a little bit more about reporting and data. So we've had access to malnutrition data for probably close to 8 years. But the EPIC platform has really given us more robust data. So now every month I'm able to get reporting based on the clinical nutrition support team's identification of malnutrition. I get information on 30-day readmission, length of stay, as well as coding. And this really has allowed us to use this data in many different ways, but also to trend these outcomes across the hospital of the University of Pennsylvania. And what I'd like to do now is to give you a snapshot of what does malnutrition look like today in our hospital. So I will direct you to the left-hand columns of these graphs, and all of this data is coming from fiscal year 20, so beginning in July of 2019 through June of 2020. And the far left column is the monthly average. And this is identification of malnutrition. So what this is telling us is that for all the patients that are referred to our service using the malnutrition screening tool, we are evaluating about 1,100 patients every month for malnutrition, and a little under 600 of those patients are meeting criteria for malnutrition. So we are identifying about 58% of those high-risk patients that are referred to us are diagnosed with malnutrition. I just mentioned coding. Again, 87% of the patients that the nutrition team will diagnose with malnutrition are being coded at discharge. For 30-day readmission, the dark bar is moderate malnutrition and the light bar is severe malnutrition. And so this is showing that our patients with severe malnutrition, 24% of them are readmitted within 30 days. And this is just about double the readmission rate across the hospital. For length of stay, we're looking at patients that were high risk but did not meet criteria, patients with moderate malnutrition, and our patients with severe malnutrition. And you can see that for severe malnutrition, the length of stay is 16 days. Our average length of stay in our hospital is about 7.4 days. So all of our high-risk patients have a longer length of stay, but in particular, you can see how length of stay increases as our malnutrition severity increases. And so the reporting has been great, but we're actually really excited to be moving into even a more sophisticated phase of malnutrition reporting with a malnutrition dashboard. And this is actually a data portal where I can simply access the portal, click on the name of the malnutrition dashboard, and what I'm presented with is a snapshot and graphic representation of what our malnutrition data looks like. And I don't expect that you can see this really well, but essentially it's giving me the first 2 months of this fiscal year up top. And it's really the same data that I showed you in the graphs. So you can see total patients evaluated, the percent identified, percent coded. The line graphs are showing you length of stay and readmission and coding, and it's giving me a snapshot of last fiscal year and the first 2 months of this fiscal year. And I think what's really exciting for this year is we're now able to actually look at severe and moderate malnutrition by service in the hospital. So we can actually tell which services have the highest percentage of malnourished patients. And then finally on the right, the data is also now distributed by therapy. So looking at malnutrition by patients receiving enteral nutrition, as well as patients receiving parenteral nutrition. So this is really, really extremely powerful. And I think finally, having this data has also supported my ability to meet Penn Medicine's research mission. This is just a snapshot of the results from my paper that was published in JPEN in 2018. I was able to use the reporting and the data that I have to look at a group of patients, about 3,900 patients, comparing malnourished patients to patients without malnutrition. The two patient groups were adjusted for age, sex, race, as well as medical or surgical service, and disease severity using the Charleston Comorbidity Index. And what these results tell you is that our patients with malnutrition were 1.5 times more likely to die in the hospital. They were 2 times more likely to be readmitted within 30 days, and their length of stay was 3 days longer. So it really does show that our patients with malnutrition have worse outcomes. And I think since this time, we are continuing to see literature and data supporting that patients with malnutrition have worse outcomes. And I think what's really exciting is some of the newer papers are using A&D Aspen criteria to diagnose malnutrition. So I think it's going to be really powerful to have a consistent method behind the data as we move forward. And so overall, what has been the impact of implementing consensus guidelines, documenting malnutrition, leveraging the electronic medical record, and having powerful data? It has had an amazing impact. I think our providers' awareness has greatly increased. I'll just give a shout out to my team because I think they've done an amazing job implementing all of these guidelines, but also in talking about malnutrition face to face with our providers, having verbal conversations where they use malnutrition to plan care for our patients. They talk about it on rounds, they incorporate it into lectures. And so the awareness across the hospital, within our provider group, within our hospital administration about malnutrition is really significant. We know it impacts quality of patient care. We have used malnutrition to develop feeding protocols. As we mentioned, there can be a revenue impact. It impacts hospital performance, again, specifically because we're able to risk adjust our patients. We're able to, it then has an impact on case mix index or acuity measure of the hospital. And then again, as I mentioned earlier, on observed versus expected mortality. There's been impact across the health system. And I think most significantly is that all of this has truly reinforced the important role of the clinical nutrition team. And so what's next for HUP? I think our focus, we have really started to pivot to start to think about what can we do after the hospital? How can we carry our care to the next level, the next setting? And how can we continue to align with the hospital's strategic objective priorities? So aligning with, discharge efficiency, readmissions, and length of stay. So with that, I'm going to turn it back over to Kristen, and Kristen's going to share with you some of these initiatives to reach beyond the hospital. Switch chairs.
All right, great. Thanks, Lauren. So like Lauren mentioned, we've done a really great job at documenting, getting data, but now we're looking at how can we take this data and how can we help our patients? We do a really great job in the hospital, but we want to continue that really great care for when they're home so they can have better quality of life at home and that they don't unfortunately have to come back to us. Even though we love seeing them, we don't want them to come back to the hospital needing more care. So this is just some studies about hospital readmissions, a lot of data that even is reflected in HUP's data, that those with malnutrition have a increased readmission rate for a 30-day, increased 30-day readmission rate. Also, their readmission the cost is higher than if somebody else who was malnourished and admitted. So these are just various studies that kind of show this. And as we, care for our patients and collecting data, we're seeing this as well. So some of the things that we have been looking at over the past couple of years to see what we can implement just to help this population. So over the past, I'd probably say like 1 to 2 years, we made a big initiative in the department to really look at how we're discharging patients. So our initiative is called the END program. So what END stands for is Enhanced Nutrition Discharge. So this was really taking a look at our patients that were going home and making sure that they were set up for success before they even left the door. So a couple things that we do work on is the first two are electronically prescribing our home and TPN and home enteral patients. So those patients that are leaving the hospital, the dietitian will put in a discharge order that's pending with the recommended parenteral nutrition or enteral nutrition prescription. So again, we've tuned them up in the hospital, we've assessed them, we know what's working for them, what they should be on at home, or if they're going to a facility, And we want to make sure that continues when they leave us. We don't want them to start from scratch or to be put on something else that might not be as optimal for them. We can also prescribe discharge diets and oral nutrition supplements, which I have a couple more slides about. And then we are, over the course of this year especially, we're working with our Penn Pharmacy on a project that we're looking at prescribing oral nutrition supplements at discharge to see if it has any impact on readmissions as well. So this is just a screenshot of when a patient is leaving, the dietitian can go in and make sure that they're prescribing the recommended diet at discharge. So again, making sure that what they're on in the hospital is continued on at home, because we don't want them to lose any ground coming out. And then not only diet, we're also looking at oral nutrition supplements. So there is a lot of research coming out that those patients on oral nutrition supplements and those that are malnourished have reduced readmission rates. So knowing this, we actually kind of took this research and formatted into a more formal program that we are working on this coming year. So we've partnered with our inpatient pharmacy here at HUP. Part of this is not a new program. The pharmacy at HUP has always provided discounted Boost Plus or glucose control at discount for any patient that has a script from a Penn provider. So for example, if a patient is leaving the hospital, we can have their attending physician give them a prescription, and they can leave the hospital with a couple cases of Boost, which is going to be basically cheaper than they can find anywhere around town here. So within this next year, we're really working closely with pharmacy and have come up with a set protocol and guideline to actually refer certain patients to this program. So the dietitian will actually go into the EMR and will actually prescribe the supplement. They will communicate that to the patient and let them know that they can pick it up here at discount. And then they kind of pass it along to our pharmacy partners, who will then visit the patient, give them more education, and in some cases will actually bring the product to the patient so they can kind of carry it out with them when they're leaving instead of stopping at the pharmacy on the way out. So this is just kind of one initiative that we're really looking at this year, just to see if it helps with any readmissions and just with obviously quality of life with our patients. So again, this is just kind of a couple things that we are working on at HUP. There are a lot of opportunities out there. Over the past few years, we've been looking at food insecurity. We have the food insecurity screening questions within our documentation that are available if able. We at HUP have actually started an employee food pantry and recently kind of partnered with them to help any employee in need of dietitian services as well. So not only are we helping our employees with any type of food insecurity, but there's partners in case management looking at longer term solutions for them. And if any of these employees do have questions regarding their diet, they have any chronic illnesses or how to use their food to the best of their ability, we're able to help bridge them through that. And as the program grows, of course, looking to see how we can take that model and bridge it to our inpatients, as we know that food insecurity is a large problem for them as well. On a more recent note, we are going to be partnering with MANNA. We're still working out the logistics, but we're planning on, especially because we have that great malnutrition database, that we're able to target specific populations who might have larger numbers of malnutrition, and looking into having them get their medically tailored meals from MANNA, and just kind of looking at the outcomes of this population to see if their BMI changes, if their readmission rate, if they do get readmitted or not, just to really see the impact, especially with malnutrition, and these medically tailored meals to see what we can really do. And then using that data, we can go forward and maybe looking at other populations or other diagnoses, depending on what we'll find with these results. So this is just a couple things that we've been working on throughout almost a decade here at HUP. And again, just kind of challenging our department and challenging people in the community to really take it to the next level, to see how can we get this great data that we have access to and to help the patients in our community. It's not just about taking care of them in the hospital, but we need to help them when they leave as well. We need to set them up and set them up for success and do what we can to help bridge them that way. So, that's our presentation. And if anybody has questions.
There we go. Thank you so much, Lauren and Kristen. That was an excellent presentation. And so I would ask all of our participants today to put any questions in the chat box if you have them. And I will start with a question for you both, and it pertains to the very ending of your presentation and that bridge to the community. As you all heard, we will be partnering with the clinical nutrition services at Penn to test our meal. Medically tailored meals and nutrition services. But I'd like to ask you what your thoughts are in regard to best practice for hospital discharge when patients who have been diagnosed with with malnutrition may need a service like ours. What do you think dietitians can do today, currently, to get patients to places like MANNA for further nutrition support in the community?
Anything that a lot of it is identifying what's available in our community, but not to the dietitian department. Can you hear us? Can you hear us, Julianne? So yeah, I think the biggest thing that we can do as a department is kind of being aware of what's available in our community, so that we can able to help with those resources. And again, we have paired, not only is it just the dietitians, but it's our case management, it's our social work, it's even our providers that are aware of programs like yours. So it's always kind of in the back of our head that we can always make that referral. Yeah, and being proactive too, and kind of asking and thinking about that before the patient's even ready for discharge.
Great, thank you. Another question was the Global Leadership Initiative, the GLIM, I think you call it, criteria is very interesting, I think, to community-based providers. What would you guys recommend is the best way for those nutrition professionals working in the community to play a role in diagnosing malnutrition, especially in partner with healthcare providers, like yourselves or the patient's physician? What would you recommend for us to use to do that?
Well, you mentioned GLIM, and I think that the GLIM criteria, what was really, the aim of it was really to cross settings. So it really wasn't just focused on the acute care setting. And it was particularly focused on clinicians who maybe didn't have a lot of time, for example, and a lot of expertise. So I think the GLIM criteria could be applicable. I think that A&D Aspen maybe. I think the bottom line is using something to identify malnutrition, and there are patient population specific tools. There's SGA, which is more than just a screening tool. I mean, there's and it really kind of depends on the setting, the resources, the expertise. But I would say looking for something that aligns with your patient population or your setting. Julianne, unmute yourself.
Yep, there you go. I had a question in the chat box. How were you able to diagnose malnutrition during COVID, the COVID pandemic?
Really good question. Really big challenge. So I think that the one thing that did extremely well during COVID was to be present and available, and to be. I think we took a lot of effort to be more collaborative with our providers and our nursing staff. You know, certainly at the height of it, we were minimizing the number of people in the room. We were also trying to avoid exposure. We used the nurses as our hands and our eyes, and the providers and the medical record to perform the physical exam in a virtual way. We literally had dietitians looking through the window and nurses pulling back sheets so that we could look at a lower extremity or an upper extremity. So I think it was a lot about partnership, but we did continue to diagnose malnutrition, and we just had to get creative, let's put it that way.
Okay, does anyone have any other questions? I'm not seeing anything else in the chat box, and it's just about 2 o'clock. So I want to thank you, Lauren and Kristen, so very much for sharing your experience and perspectives today. I know I learned a lot, and I'm sure everybody on the webinar learned a lot, and we appreciate it very much. We will be sending, as I said, we'll be sending the CPEU certificate out for anybody who needs it. 1 CPEU for registered dietitians who are on the call today. Thank you again for joining us, and we'll look forward to having you at future seminars. This was the beginning of a seminar series, so we will inform you of our next one, which will be in a couple months. Thank you.
Thank you.